Welcome back to Clinical Problem Solving. We are on week 4, and today we're going to be talking about how we start with our tiered differential diagnoses and then use diagnostic tests, whether they're blood tests or x-rays or other imaging studies, to refine our differential diagnoses, hopefully arriving at the correct diagnosis for our patient. So let's get started. I just want to warn you that we'll be doing some math in the middle of this module. So if you want to have your smartphone or calculator or computer calculator open, you'll find it useful in the middle for those of you who want to work along. But don't worry, if you don't have one of those things, we have clear examples on the screens. So let's get started. Once again, I want to acknowledge my collaborators, and there's a new one this week, Mitch Meadow, who's worked with me at Ohio State and is currently at the University of Arizona, and some of his work will form our heuristics later on. Just a brief review of modules 1, 2, and 3, and I know you are all getting this information well from seeing the homework. So in the first week of the course, we talked about how experts store memories about disease, and they store it in these packages of information known as disease illness scripts. All of us have thousands of these disease illness scripts in our brains, and they're somewhat unique to us, but they are based on 4 core elements of fact. One is a statement about epidemiology, who gets this disease, what risk factors and demographics are most commonly present in this disease, how the disease presents with respect to time, whether it's acute, subacute, or chronic, what are the classic signs and symptoms of this disease, and then what are the biological mechanisms of this disease. We then talked about how we take information from our patients in a history and physical and arrange it in such a way that we can create a patient illness script. And the patient illness script has very similar elements. A statement of the patient's epidemiology, what we consider to be the most important aspects of this patient's demographics or exposures in terms of the question that we're facing. A statement of the time course of the patient's symptom, a syndrome statement, and then any other relevant information we want to include. We use those 2 frameworks, the patient-based illness script and the disease-based illness script, because they look similarly, and comparing and contrasting them, we can then tier our differential diagnosis. A tier 1 possibility is clinically high likelihood or very high likelihood, and that exists if the disease-based illness script can explain everything we see in our patient's illness script. And conversely, if the patient's illness script has all the major manifestations of the disease. Importantly, a disease can only be high likelihood or a tier 1 possibility if the patient has no rejecting features of that disease. So there's nothing in the patient's presentation that is never seen in the disease in question. So that would be a tier 1 possibility. At the other end of the spectrum, a tier 3 possibility is a clinically low likelihood, and we're going to denote that in today's slides in this kind of red area. In that situation, the patient has only a single or maybe just a couple features of the disease in question, or they might have one of those rejecting features. So they might have a sign or symptom that's never seen in the disease in question, and that will decrease the clinical probability to low or very low. And in between is what we've called tier 2 possibilities. These are clinically moderate likelihood, sort of in the 33 to 66 range. This is present if the disease that we're considering in this tier explains most but not all of the patient's finding, and if the patient lacks some of the usual manifestations of the disease. Some people also in the clinical problem solving arena call this uncertain probability of disease. This would be very likely, very unlikely, and uncertain, and we'll use those terms interchangeably today. Now, in terms of helping us use our diagnostic tests, which is what we're going to work on today, it's sometimes useful to put a numerical probability on top of our clinical probabilities. So again, using the green means very likely and red means very unlikely, we can create a spectrum of numerical probabilities that we'll use mathematically in our environment. And so we start off with tier 1, tier 2, and tier 3, as we just talked about. And I'm going to subdivide tier 1 into likely, so somewhere between 67 and 90% probability, and very likely, which is greater than 90%, and you'll see why we're doing this in a few minutes. And for our work today, I would say that something moves from likely to very likely if there's a defining feature present, that is, something that really classically describes this disease. And at the other end of the spectrum, I'm going to divide tier 3 into unlikely and very unlikely, only being very unlikely if there's a rejecting feature present. Now, for those of you who have been working very diligently on these tiering, you'll recall that I am not talking about tier 1E in this spectrum. 1E, remember, is a 2 or a 3 diagnosis that would be considered early in our therapeutic algorithm just because it's an emergency disease. For the purposes of today's talk, we don't have to spend too much time on that information. So let's start with our new content for Module 4. And by the end of today and completing the homework today, we're going to hope that you achieve the following objectives. The first is I want to make sure that you understand how to correctly use diagnostic tests to evaluate your differential diagnosis. Very often we fall into the trap of saying, oh, the test was positive, so the patient has the disease in question. And by the end of today, I hope you should understand and be able to explain why that isn't always the case. First, we'll review test characteristics of sensitivity and specificity, and then the test performance statistics of positive predictive value and negative predictive value. Some may be very aware of these terms. Don't worry, we'll define them as we go along. So if this is new to you, keep going. You'll be happy at the end. Secondly, we're going to use our tiered differential diagnosis to interpret diagnostic test results in a way that helps our patient. And finally, we'll be able to begin to understand how errors occur if testing is used without considering these concepts that we'll review today. And next week's module, Module 5, is all about diagnostic mistakes, how they occur, and what you can do to prevent them. So I'm going to have you work along with me for this next case. You're used to looking at cases now and developing problem lists, and I'm going to ask that you take the next case, and as I describe it, jot down your problem list, process it as much as you possibly can, and then we're going to move directly to a summative patient illness script to launch our work on diagnostic testing. This is a case of Mrs. Triglioni. You might remember Mrs. Triglioni from week 1 who had a chief complaint of dizziness. It's the same patient. This is the symptoms that preceded her dizziness that landed her in the hospital. So let's start from the beginning of the case. It's a very interesting and compelling case, and we'll have lots to talk about. So get busy with your problem list as I read. Mrs. Triglioni is a 48-year-old woman who underwent knee reconstructive surgery 3 weeks ago. She's been doing pretty well until she developed some sharp chest pain in her left back this morning and some breathlessness. She's a visiting nurse by profession, and so she checked her pulse oximeter and found that her oximetry was slightly low at 94%. She has a mild cough and a low-grade fever. She's had swelling and redness in her leg up to the mid-thigh on the leg that was involved in the surgery, but she was told that was to be expected after surgery, and she doesn't believe it's any worse than it was yesterday. Her past medical history is notable for high blood pressure. Her social history, she's married with 2 children, and she has a contrast dye allergy. Medications on admission include aspirin daily since surgery and Percocet for pain. She calls you on the phone and asks for advice about what to do. She ventures the opinion that maybe she just has a muscle strain from using crutches, or is there something more serious that she should have a test for? So, as I said, let's make sure that you can process her problems and make a prioritized differential diagnosis. I'm going to skip ahead and show you what I constructed for her patient illness script, and then the differential diagnosis that my team has developed. So here's her patient illness script. Epidemiology, she's a 48-year-old woman who's 3 weeks post-operative, so post-operative and leg surgery. Time course is acute. She was fine yesterday, and today she has this new symptom. Her syndrome statement is pleuritic chest pain. Her pain got worse with increasing breathing. Dyspnea, processed from shortness of breath and breathlessness. Non-productive cough. And probable hypoxia with that pulse ox of 94%. Associated with unilateral, there's a distribution-based processing, leg swelling, and erythema, and we could call this edema. if we wanted to process a little bit more. And her other past medical history is hypertension. So we're looking for a disease that matches this patient's illness script. And tier 1 diagnosis was, according to my team, an acute pulmonary embolus, explaining the postoperative sitting and acute symptoms, pleuritic chest pain, hypoxia, and evidence of a DVT. Tier 2 diagnosis was hospital-acquired pneumonia, incorporating the non-productive cough and a little bit of a low-grade fever. Could also cause the same symptoms for pulmonary embolus, but we want to expand our differential diagnosis to make sure we don't close too quickly on pulmonary embolus. And tier 3 was Mrs. Triglioni's thought or hope, perhaps, that this chest pain just represented a muscle strain. And so we recognize, of course, that a muscle strain really can't explain the pleuritic chest pain, the non-productive cough, the hypoxia, or account for the leg swelling. So, first quiz for Module 4, what advice should you give Mrs. Triglioni based on what you've heard on the telephone and the work you've done to process her problems and develop a patient illness script and differential diagnosis? So number 1, increase your dose of pain medications, Mrs. Triglioni, and call me in the morning. Keep the same dose of pain medications but use a heating pad on your back, or return to the emergency room for an evaluation. And hopefully, given the fact that your tier 1 diagnosis was pulmonary embolism, you chose number 3. Return to the emergency room for an evaluation. So the next conversation you have is you call Mrs. Triglioni back after thinking and tell her you really think she should go to the emergency room because you're concerned she could have had a pulmonary embolus. She's pretty reluctant to do so because it's such a chore to get back to the emergency room, and asks you how certain you are that she might have had a pulmonary embolus. Is this something you really need to be concerned about? Deciding to look for more evidence, you consult your references and find a clinical decision support tool, the Wells criteria, and decide to check your own clinical problem-solving skills with what the experts have identified as a way to develop a probability of pulmonary embolus diagnosis. So here's the Wells criteria. We're looking for a pretest probability of pulmonary embolus before we do any diagnostic maneuvers for the possibility of this disease. And the important features for the Wells is, does the patient have a clinical sign or symptom of DVT? We would say yes, because Mrs. Triglioni has a swollen leg. It's possible it's related to the surgery, but in fact, she has the signs and symptoms of a DVT. That gives her 3 points. Is pulmonary embolus the number 1 diagnosis or equally likely? Well, in our pretest probability, we said it was a tier 1 diagnosis, so I'd say that's pretty darn good, and that gives you 3 points as well. Is her heart rate greater than 100? We actually didn't ask that information, and this would be something you could go back and ask her to check, but if it was present, she'd get another 1.5 points. Has she been immobilized for 3 days or had surgery within 4 weeks? Do you see how important that epidemiologic statement was, that she is somebody who is 3 weeks post-op, because that puts us right in the window where she's going to get some points on the Wells criteria. She has no prior history of DVT. She has no hemoptysis or coughing up blood, and she doesn't have malignancy with treatment within the last 6 months. So if we were to add up what we know to be true, we give her 3 points for this clinical signs and symptoms of DVT, 3 points for pulmonary embolus as a likely diagnosis, 1.5 points for surgery within 4 weeks, and that gives her 7.5 points. And on the Wells criteria, that puts her at high risk of pulmonary embolus. If her heart rate is greater than 100, which it wouldn't surprise me if it was, just given the situation we're dealing with, she'd just be at even higher risk of pulmonary embolus. So this is just a good example where your clinical pretest probability, even before we use this decision support tool, agreed with the results you got in the Wells criteria. So there's some internal validity here, and you should be happy with your tiering if you also selected pulmonary embolus as a high likelihood. Just in terms of testing yourself, you decide to make sure that this wasn't just a fluke case. So you pulled out Mrs. Garcia's case. Remember Mrs. Garcia? She's the woman who presented with shortness of breath that we believe was related to a pleural effusion associated with a malignancy. You had listed pulmonary embolus as a tier 1E diagnosis. You had actually thought it was really a tier 3 diagnosis because the clinical presentation didn't at all appear to be related to pulmonary embolus. So you use the Wells criteria, Mrs. Garcia's clinical information. I want to say parenthetically, this is a great thing to do in order to reinforce your understanding of the differential diagnosis for both Mrs. Garcia and Mrs. Triglioni, because anytime you have the opportunity to pull out information you used in the past and reconnect it with a new case, it cements those memory nodes in your brain. So this is a tremendously successful strategy to use if you want to continuously reinforce and refine what you're learning as you move through your career as a physician. So here's the Wells criteria applied to Mrs. Garcia, who's clinically a tier 1E of pulmonary embolus with a bona fide pretest probability of about 10%, or tier 3, very unlikely. Did she have clinical signs or symptoms of a DVT? Remember, she had no lower extremity symptoms other than a little bit of decreased pulses. So it looked like arterial insufficiency with no venous problems. So no points for that. Was pulmonary embolus a number 1 diagnosis? No. We had a different number 1 diagnosis. Her heart rate was, in fact, greater than 110, so she gets 1.5 points for that. She had not been immobilized or had surgery within 4 weeks. No previous history of DVT, no hemoptysis. And malignancy with treatment within 6 months, we were considering malignancy as part of her differential diagnosis, but we don't know it to be true. So by using this criteria, she would not get points for that. So her score, in contrast to Ms. Triglioni, is 1.5 points, and therefore she has a very unlikely risk of pulmonary embolus. So what this shows us is that, again, tiering by clinical problem solving can be validated using other decision support tools. If we had found a different outcome, it would make us go back and rethink our case. But good news, we seem to be congruent with what the experts are saying. So congratulations. What we've been learning in the past several weeks is helping us make good decisions. And now we're going to take the next step and figure out how we take those clinical decisions, those made based on history and physical, and use established diagnostic tests to refine them.